Good morning, sir. Good morning, everyone. I am Sadhu Hussain and my co-presenter Vishnu Vit. We are going to present a case. So, Mr. Prabhas, a 60-year-old man from Nagarkoil, who is a farmer by occupation, belonging to low middle class according to modified Cooper's Promise rate, came with expectoration. Sputum is white in color, mucoid in consistency, moderate amount, non-bandaged, not foul smelling, aggravated during morning. There is no relieving factors and it doesn't have any diurnal variation and no seasonal variations are present. He also complains of breathlessness since last 4 months, insidious in onset, progressive, initially experienced while climbing stairs, but now present even after walking for a few minutes on a level ground, and it relieves on taking rest. There is no history of orthopnea, PND, pedal edema, abdominal distension. Patient has no history of fever, nasal discharge, running nose, nasal obstruction, headache, and the patient doesn't have any history of chest pain, loss of weight, appetite, no history of chills, rigor, and evening rise in temperature, night sweats, and there is no history in the change in the voice, no history of oliguria and hematuria. Past history: the patient experienced recurrent episodes of cough with expectoration, but has no history of previous hospitalization for the same. Patient is not a known case of diabetes mellitus, hypertension, tuberculosis, asthma. There is no history of fever with rash in childhood, no history of seizure disorder with loss of consciousness in the past. Occupation history: there is no history of exposure to any chemicals, organic dust, and there is no history no history of any relevant occupations. Family history: there is no history of similar complaints in the family, no history of tuberculosis, bronchial asthma, malignancy in the members of the family. Personal history: the patient has a mixed diet, his appetite is normal, and his sleep is disturbed due to cough. Bowel and bladder habits are regular. A patient is a chronic smoker since last 45 years, 10 BDs per day, which makes a pack years of 22.5, and he is a non-alcoholic. Treatment history: there is no history of any use of inhalers, nebulizers, no history of any radiation exposure in the past, no history of any surgery in the past. Summary: a 60-year-old man from Nagarkoil, who is a farmer by occupation, came to OPD with complaints of chronic cough with expectoration for past 4 months, with the sputum white in color, mucoid in consistency, and no history of foul smelling and bloody discharge, and which is aggravated in the morning. The patient also complains of breathlessness, which is progressive in nature, initially during climbing upstairs to walking at a ground level. According to the above history, the patient is probably suffering from respiratory system disease.
Why do you say it is respiratory? I say it's a cardiovascular. In the morning itself, I told both they have a very similar complaints.
So the patient have cough with expectoration, and the patient also have the history of smoking, breathlessness. So
Okay, cardiovascular also can have a smoker. Smokers can have associated cardiovascular. Why do you say it is respiratory? It is not cardiovascular. Still you can have, sad not we will have, but to a certain extent we can say it is respiratory.
the patient also doesn't know the history of any chest pain, sir. Then no history of any abdominal distension period, then no history of any right heart failure. Then due to this, first of all, the patient may have it's a typical patient of a respiratory failure, sir. It's a respiratory case because the age is above 45, sir. Firstly, and he also have chronic cough for past 4 months, right? So for long duration of cough.
So it is a long duration can happen in chronic respiratory failure. The thing is always you should think about as history of PND, orthopnea, and other chest pains. These are things that are not there, so it could be respiratory. So you have to exclude cardiac. Both are closely related, especially COPD and left ventricular failure. We may find it very difficult to differentiate in the initial cases. So you should have that in your mind.
So you thought of a respiratory disease, agreed, because of the absence of other symptoms and signs of symptoms of cardiac involvement. You thought of a respiratory disease. What is the disease or what are the diseases which can present like this?
So like,
Can you go back to the summary previous slide? 68-year-old man with 4 months of cough and progressive breathlessness. He has a high smoking index or a fat here. And you know the history, you suspected a respiratory disease. What respiratory disease are possible?
first of all, the patient is suspected. First of all, there will be differential diagnosis of emphysema. Then chronic bronchitis may be there, sir. Then bronchitis may also present.
So first possibility thought of is chronic obstructive pulmonary disease. If COPD is your first possibility, how will you justify that? Why you thought of COPD? What are the main points?
Sir, first of all, the age of the patient is above 45 years, sir.
He is 68 years old.
Sir, the patient is also a chronic smoker, sir, for 45 years. The patient complains of acute exacerbation of cough with breathlessness. No, sir. Cough with breathlessness.
So there is an adult more than for 68 years. He has 2 risk factors. He is a farmer, maybe exposing to a lot of dust, etc. And he is a smoker with a 22.5 or a high smoking index. What is smoking index?
Smoking index is the how many
Number of cigarettes
the
smoked in the number of years. Simple. So high smoking index or a fat year in a 40-60-year-old man coming with cough with expectoration and a progressive breathlessness. We have to think of the possibility of a chronic obstructive pulmonary disease. Okay. Any other possibility? Any other lung disease can present as 4 months cough and progressive exertion breathlessness.
Sir had told in the morning, we can use that also. One of the differential diagnosis.
interstitial lung disease.
Very good. It can present as more or less before expectation or hypoxic, excess breathlessness. So there are 2 diseases which are progressive in spite of your treatment in respiratory disease. Number 1 is COPD, number 2 is interstitial lung disease. Any patient you are getting for a case with progressive breathlessness from grade 1 to grade 3 or grade 4, whatever it is, if it is progressing, you have to consider COPD and ILD in their differential diagnosis before clinical examination. Any other possibility? 4 months cough in India. Tuberculosis. What is preventing you? From the history you can suspect. No. May not be tuberculosis, lot of negative points. But so we will give 3 possibilities from the history. Chronic obstructive pulmonary disease, interstitial lung disease, and tuberculosis. Okay. Now we will go to the physical studies to make a proper diagnosis.
So general examination, after getting consent, the patient was examined in a well-lit room in sitting and supine position with me standing on the right side of the patient, moderately built and nourished, conscious and well oriented. There is no pallor, no icterus, no cyanosis and no clubbing, no lymphadenopathy and no periodema present. His vitals, pulse rate is 85 beats per minute, respiratory rate is 25 per minute, blood pressure is
One more thing, how much time you take for counting the pulse? So usually we will count for half a minute and we will usually. So better not to make it an odd number, it should be even number. But sometimes the examiner will insist on it. It should be even number. At the same time also, the past children don't write no family, no not diabetic, not diabetes, because hypertension and diabetes is not going to be a past illness. It will be there, so you give it in any personal history. Don't give hypertension, diabetes as past illness. These are small things, but in those days when we were all penalized for that. The same way, blood pressure we will not be in odd number unless you have a digital BP apparatus. Always will be in even number.
Then the SpO2 ratio is 90%, temperature is 98 degree Fahrenheit. Examination of the respiratory system, the upper respiratory system, the nasal cavity is normal, oral cavity normal, the pharynx appears to be normal. Then examination of the lower respiratory tract inspection, chest is barrel shape and bilaterally symmetrical, trachea appears to be in center, type of respiration is abdominal thoracic, apex feet cannot be visualized, use of accessory muscles of respiration seen, no dilated veins, scar, sinus and visible pulsation on the chest wall, kyphosis and scoliosis, or drooping of shoulder is not present, no indrawing of intercostal spaces. Then chest movement appears to be reduced, areas of chest wall anteriorly supraclavicular, infraclavicular, and mammary. On both sides it appears to be reduced. Laterally, axillary and infraaxillary region, it appears to be reduced on both sides. And posteriorly, suprascapular, infrascapular and interscapular appears to be reduced on both sides. Then on palpation, all inspectory findings are confirmed. Trachea appears to be in the central position. Apex beat in the fifth intercostal space, lateral to midclavicular line. No local rise in temperature and no tenderness present over the chest region. The movement of the chest appears to be reduced. Then chest movement, area of chest wall anteriorly on both right and left side it appears to be reduced. The local femmeters, areas of chest anterior, lateral and posteriorly it appears to be reduced on both sides. Then measurement, anteroposterior diameter is 25 cm, transverse diameter is 30 cm, chest circumference on expiration 98 cm, chest circumference on inspiration is 100 cm, the chest expansion is about 2 cm, the right hemithorax expansion is 1 cm and the left hemithorax expansion is 1 cm.
Can you put the previous slide? Previous slide. So when you report the move also from this, okay, supraclavicular.
So then on percussion, directly percussed over the clavicle is resonant on both right and left side. Then using the indirect method, the areas of chest wall like anteriorly supraclavicular, infraclavicular and mammary region shows hyper resonant on both sides. Then laterally axillary and influx region shows hyper resonant on both sides. Posteriorly supraclavicular, infraclavicular and suprascapular, infrascapular and interscapular shows hyper resonant on both sides. Then on auscultation is of vesicular breath sounds here. The intensity of the breath sounds here on both right and left side appears to be diminished. Then presence of scattered rhonchi here over the chest region. It's of polyphonic in nature and local resonance diminished on all areas. Then examination of other systems, CVS S1, S2 here in all areas, no murmurs audible. Then abdominal examination, no hepatomegaly, no splenomegaly and no shifting blood vessels present. CNS examination, conscious and is well oriented, no focal neurological deficit. The provisional diagnosis is
In the morning, Sarah has told something. Have you noticed? Have you included that in this? That is why we are particular about that. How do you say it is hyperresonant? Why do you say hyperresonant? Why do you say it is hyperresonant? What do you have to look for? Sarah has told what important finding in the morning.
That is missing, that's why you asked for this. You mentioned all areas as resonant.
in low loop there may be due to presence of pulle or other air trapping there will be hyperresonant than the normal.
What is the hypersonic due to?
So due to air trapping.
If air trapping happens, the lung becomes hypersonic. What will happen to the lung?
Hyperinflated.
So what are the signs we look for hyperinflation?
The intercostal space will be increased. Then there will be
The percussion will
percussion, all areas are hypersonic. Your explanation is
so the supraclavicular region we have to focus.
right, Parvala. Sarah has told one more thing, the most important thing. Idle percussion. Where is the liver dullness? Sarah has told some numbers also. Can you remember anybody?
579.
That is
That is normal.
enough.
6, 8, 10.
So you may have one or more space, maybe resonant. You should look for obliteration of cardiac dullness. That is very important. So cardiac dullness will be obliterated, lower part will be a little bit lower down. That is very important. Sarah has told in the morning.
This patient is one of the most important findings, whether the lung is hyperinflated. Tidal percussion is the one which you should not miss in this patient. You are getting few wrong age, you are getting hyperresonance all over. But one finding which will confirm the COPD hyperinflation is your tidal compression and maybe obliteration of the cardiac dullness and sometimes Prof also. So that we have to.
So the Gross diagnosis, a 68-year-old.
What did you look for? PG's cardiovascular system.
What specifically you look for in this particular patient? There is bilateral hyperresonance. Definitely this patient's cardiac function will be 6 8 10 or 29. So that's hypertension. So in this patient, other system examination, CVS, what you specifically look for? Cardiac obliteration is part of emphysema at the stage. That's to do with the heart.
Clinical examination, cardiovascular disease. Ask and get in the cardiac area.
That you have to
So postgraduate. You have to do that. P2 should be known.
very good. You have to look for the commonest cause of secondary pulmonary hypertension due to respiratory disease is chronic obstructive pulmonary disease. The prevalence is very high. So in all COPD patients, you have to meticulously look for the signs of pulmonary hypertension. What are the signs of pulmonary hypertension? What's
There
the
will be right heart failure, pedal edema,
Yes.
then abdominal distension.
Yes.
Then also
Very good. Elevated JVP. Yes.
So all the signs of right heart failure, but specific to the pulmonary hypertension, now which is closely split and do not vary with the respiration. That's the classical WP2 in secondary pulmonary hypertension. But that's not enough. That's not okay. WP2 is enough. You look for the WP2. Then left parasternal fee. Sometimes patients story marker also you can get.
Sometimes you have tricuspid
Tricuspid marker also. These are the signs of pulmonary hypertension. When you go to the pulmonary, you will get pedal edema, JVP, etc. So very important, at least in the respiratory system with emphysema, D2 whether it is normal, S2 normal, here to be.
What general examination finding you will look for? COPD. Policy, very good. First thing, briefly. Tripod position, very good.
blue lotus and pink.
Blue lotus, pink buffer. Two extremes of COPD.
Campbell and Campbell's. Campbell's. So Campbell's.
What?
Campbell's.
Campbell's neck. What is that? So what is your diagnosis?
The Gross diagnosis acute exacerbation of COPD with predominantly of emphysema.
We made a diagnosis of emphysema. After clinical findings.
Chest is hyperinflated. The chest is hyperinflated.
Chest is hyperinflated. Hyperinflated finding you are supposed to report that also. So evidence of hyperinflation plus. One is typical dyspnea, smoker with exertion dyspnea. Number two, evidence of hyperinflation as indicated by the tablet profession. Then bilateral hyperresonance and bilateral bronchial polyphonic bronchial also. This is more than enough to make a diagnosis of COPD. My diagnosis is asthma. What is your points against?
There is no history of any allergy history is not
That will
present.
not be there.
There is no family history.
Clinical findings.
History also. Sarah stored in the Yes.
Public expectation is not very common in asthma. It is common in
The
COPD.
episode even in case of asthma.
Yes. Progressive pregnancy.
Another is episode. Then clinical examination. Hypertension is not a feature of asthma. It is COPD. And hypersonus is not a feature in asthma. It is a feature in COPD. So you are getting asthma is not a feature. My DD is interstitial lung disease. Why? No.
no active infection.
Interstitial disease.
So there is
What sign you will look for?
there is no cyanosis present.
That can happen. One finding which is can be there in 70% of cases of ILDs can be. Number two, auscultation. Instead of Romeo, what will you get? You will get wide repetition, which is more in the end of inspiration. We call it as end inspiratory repetition. For ILD,
What we call is Velcro.
even though you may not say Velcro, I never heard what is this Velcro. Tailman, fine leather. Okay. At least you can say end inspiratory repetition. Minimum you can say inspiratory repetition. That is absent in the patient. Okay. Number two, interstitial lung disease. If at all produce, it will produce reduction in lung volume. Here there is a patient with increase in lung volume. And no repetition for interstitial lung disease out of question. So your diagnosis of COPD, predominantly emphysema is correct. As we discussed in the morning, you suspect COPD in a patient when there is a respiratory exposure and adult with cough and breathlessness or expectoration. You suspect, do clinical examination. If you get evidence of hyperinflation from throat gate, it is emphysema. If there is patients with bilateral crepitations without hyperinflation, go for chronic bronchitis. Always look for the evidence of cardiac involvement, especially loud P2 for pulmonary. Okay. What are the investigations you do for this patient to confirm the diagnosis?
So first of all, I will do spirometry, sir, to look for whether there is after giving salbutamol and like beta agonist like things.
Spirometry, when will you say there is COPD?
Sir, if it is less than 70% and there is no increase in the lung volume of 200 ml and also 12% if it's not increased.
What is less than 70%?
FEV1 by FVC ratio.
FEV1 FVC ratio less than 70% indicate obstruction. No reversibility, you can confirm COPD. Okay, but one take-home point I will give you is, even if the respiratory system is normal in this patient, can you rule out COPD? So any patient with risk factor exposure like smoking, coming with the respiratory symptoms, even the respiratory system examination is normal, COPD is a possibility. So the test of clinical examination cannot rule out the possibility of a COPD. Early COPD will be normal. Only spirometry will help you to make a diagnosis. Okay. One question also. So suppose the spirometry is showing a borderline reversibility. Asthma is also a possibility. Any test which can differentiate between asthma and COPD? Spirometry is not very confirmatory. There is borderline reversibility. Patient is focused. You ask the patient, do you have episode? Do you have exertion? It confuses you. What we can do? You do a spirometry which is also confusing you. What will you do? There is a test called diffusion lung capacity, DLCO. Have you heard of that? In COPD, what happens? Because the alveoli is damaging, the diffusion is reducing. So, taken from me, all cases of COPD or most of the cases of COPD, DLCO will be reduced. So, in asthma, it will be normal. It will be normal, even slight increase can occur in asthma patients. So, just for an additional point, we can use DLCO as a differentiating between asthma and COPD in addition to your clinical.
Is there complication you will anticipate? Right heart failure and your ventricular. What you have to look for are these things. Pneumothorax, right? Pneumonia may be there. PGs.
What are the systemic effects of COPD? That's what I is asking.
Systemic effect as well as complications.
It
It's not a lung disease, it is a systemic disorder. COPD is a systemic disorder.
The most common complication is cardiac involvement. Number one.
Other than that,
So pulmonary embolism.
Huh? Pulmonary tuberculosis.
it's not specific.
That's not a complication of COPD per se. What are the other complications or comorbidities or systemic effects of COPD? Being said that COPD is a systemic disease.
What are the things you will look for? What complication you will look for in the physical examination also? What about muscle, mental disorder, bone, osteoporosis can happen, muscle, wasting can happen, depression.
Mental unconsciousness, mental illness.
One more important thing, PGs should say. That is why I'm asking. That point, none of them has touched. Huh? Respiratory failure, they will go for respiratory failure. What will you look for in the beginner, postgraduates? Clubbing, what does clubbing means in a COPD? Bronchogenic carcinoma. What are the things you will look for in bronchogenic carcinoma in COPD? What is clubbing? Then SVC obstruction about particular. What are the things you will look for in SVC obstruction? So postgraduate, we should tell these things. Sudden increase in size of the neck. Then what else the feature of SVC obstruction? Breathlessness will be there. Then non-pulsatile JVP. There you will not have upper level, will not be seen. That you should show. At least you should know, you should look for a clubbing, you should look for increase in size of the neck. Non-pulsatile JVP you should look for.
So these are the common complication or systemic events of COPD. Number one is cardiovascular events. Number two, depression, because the patient will not get satisfaction with your treatment. It's a non-reversible disease. 50% of the COPD patients are depressed. Muscle wasting, osteoporosis, CNS surveillance, stroke is more common, carcinoma lung. It is said that compared to a smoker who doesn't develop COPD, a smoker who develops COPD is 5 times higher chance of developing carcinoma. So in clinical examination, you can look for the presence of clubbing or even the other sites of if it is superior circus, you will have findings of this. So what is the early symptom for development of lung cancer in COPD patient? By which you have to suspect. Clinical examination finding will come later. By the time you detect clinically you have disease like SVC or something. So you all COPD patient will have a habitual pattern of cough. Okay. When that cough pattern changes or when there is a blood in sputum, these are the two early signs of development of cancer. Any COPD patient telling that, sir, my cough is now it's different. Previously I had a cough in the morning, I spit out sputum, now it's clear. Now at daytime also I am having cough. So change in the pattern of cough or blood in sputum. These are the signs to suspect CLN, where it is 5 times more common than a patient with a equal number of smoking with no COPD. So COPD is from this factor 4.
Coming to the back here, how many back here will cause COPD? How many back here will cause CLN? More than 20 for COPD, more than 30 for malignancy. Graduate is a must, you should know all these things. One more risk factor for COPD is more than 55 years if you have a start load feature. Gold guidelines says you should have more than 55 years and 35 years are prone to develop malignancy.
So once you confirm your diagnosis, how will you manage COPD? You read as biometric, is the next slide, there is emphysema, there is hypertension, poor reversibility. How will you manage this patient?
I ask the patient to cessation of smoking.
Very good. So always remember, just don't get that I will do yaba bronchodilator. The most important thing is removing the risk factor, especially smoking. I want to hear that. If I hear that, I will be happy and then we full mark for treatment. Rather than saying bronchodilator this. It's a irreversible disease. Smoking prevention and that is very important. Then we can divide into pharmacotherapy and non-pharmacological therapy. Pharmacotherapy gives non-pharmacological, you have to.
Lifelong oxygen therapy.
No, if hypoxia is there, oxygen therapy. You can give pulmonary rehabilitation, very, very important. Now the guidelines is very strict on giving pulmonary rehabilitation to all COPD patients. You can give breathing exercise, you can give muscle exercise. So once you strengthen your muscles, respiratory and peripheral muscles, the breathlessness will decrease. And you can give immunization, vaccination, health education. So the answer I want is smoking and counseling and cure for smoking. Pharmacotherapy and non-pharmacological we can include with required oxygen therapy, immunization, pulmonary rehabilitation, and
Lung volume reduction surgeries can be done.
that's extremely rare cases. You are not actually common. Data on that. Smoking index is calculated by number of cigarettes in number of years. Suppose the patient smokes 10 cigarettes for 1 year, the smoking index is 10. 10 into 10 years is 100. To convert into pack years, we can divide it by 20.
Because 20, because in Western countries, each packet cigarettes will contain 20 cigarettes. Not in India, they have only 10 cigarettes. That is why it's hard.
And the BD is available in Kannur and Kerala also. So Western country BD is not there, but there is a rough calculation. Actually, it is almost equal. The carcinoma content is equal, but there is a rough calculation. Is divided by 2. Like that, he calculated 22.5 like that. But there is no guideline to say how you convert. With the question is right. I am not aware of a formula which can convert from cigarette to video. I am not aware of that.
How to quantify alcohol? How to quantify alcohol in case of occasional drinker? He drinks occasionally, maybe weekends, monthly twice.
I don't know exactly, but there is some number of grams there. This is grams, it is not in the ml, it is in the gram. Western book says. I don't know exactly, I don't remember that. But one thing you should remember is even single drop of alcohol will cause damage to the liver. That you should remember. Don't think the alcohol is good for your health. Somebody will say it's good for your health. Even a single drop of alcohol will cause damage.
But if a person taking less alcohol, so that increases the HDL3, HDL level, HDL1. HDL3 is the most important thing. So that will protect the heart. So when you take whole HDL, HDL is the protective, but it contains 1, 2, 3. Alcohol increases the total HDL level, but HDL3 is the portion that you need to avoid for CAD. But alcohol increases HDL1. But when you take total HDL, HDL is rising. Understood? So HDL3 is the important factor to prevent coronary. But book says that teetotaler is having a high risk for CAD than. Don't ask these questions to your respiratory physician. But an excellent session. Actually, it's a tsunami session because we have got various aspects of. Don't worry, sir may join us in May. Sir may join us in May, but you will be interns by that time. But even then, you can use his service when you are in intern also. So such excellent teachers. So we have got such excellent teachers. So you see.